Rajdeep.
A very warm good afternoon to everybody. I would like to once again extend a warm welcome to all the respected dignitaries and delegates to today's webinar on health communication skills for nurses. So yesterday we inaugurated this webinar and we had two sessions yesterday, and this is a continuation of the same topics. So today we'll be again coming across two distinguished personalities who will be highlighting on the communication skills for nurses. So without any further ado, I would like to hand over the session to the moderator for scientific session, Mrs. Gautami. Over to you, Gautami, ma'am.
Thank you, sir. So, without any further delay, to discover the importance, of this communication skills, let me introduce the most eminent speaker of today's session, Dr. Stanley Mukundan, who is a palliative care consultant from Bangalore Baptist Hospital. Sir is also a national coordinator for Christian Medical Association of India for its palliative care programs. Sir has led Project India of Interprofessional Collaboration for best care for the dying person, University of Liverpool, UK. Sir is also a management consultant, National Fellowship in Palliative Medicine and Nursing Joint Program of CMI, Calicut. Sir has served Bangalore Hospital for almost 24 years, leading as Palliative Care Department HOD, fully integrated program for almost 25 years. Sir was the past secretary and national faculty for Indian Association of Palliative Care, and Sir served as palliative care consultant in several medical experiments. So it's our pleasure to wholeheartedly welcome you, sir, for the webinar, and going to deliver the talk on the topic that is critical communication skills for palliative care patients and their families. Over to you, sir.
Thank you for that kind introduction. I am grateful to the organizers of this important webinar for their kind invitation, and I thank Sister Lena for this opportunity to learn and share. So I'll just do the screen sharing. Is the screen visible?
Yes, sir, it's visible, sir. You can
Am
proceed, sir.
Am I audible?
Yes, sir. Everything is fine. You can proceed, sir.
Okay, thank you very much.
Thank you, sir.
So good afternoon, everyone. And yesterday, in all the presentations, the one message which kept coming is we need to communicate from our heart. Yes, friends, we all know about the art and the science of medicine and nursing, and palliative care is an excellent platform to practice the heart of medicine, to learn about the heart of medicine and to apply it everywhere as we deal with various kinds of patients. And that is why the WHO, in its recent resolutions, has emphasized that palliative care should be an integral part of all healthcare. All healthcare. So today, in this session, I'm going to talk about communication in palliative care. So just a little understanding about our palliative care program in Baptist Hospital. We started in 1995. It's a fully integrated program. In other words, it is part of the services of the hospital. And since we are a fully comprehensive cancer center and a tertiary care medical center, it is for all these disciplines. It is for oncology, cancer patients, and also all the non-cancer patients, the end-stage medical diseases, and everyone who needs palliative care. So we have outpatient care, inpatient care, and home care, and we provide bereavement support for about a year after the death of the patient. And we also have volunteers' involvement, training, and research. And the picture on the right is from one of our earlier brochures, which shows the emblem of our palliative care program, which shows the flower of the opium poppy. So it is a good way that we can talk about this important medicine that is used in palliative care. Also, we have the pod, which looks like a chalice and a little cross on it to signify Christ. And the green leaves also signifying new life, and the yellow rays of hope, the hope in Jesus, who said, I came that they may have life. So we are communicating through this brochure and this emblem that we are a team from a Christian background and that we are there to help them and to provide all the necessary things that may be required. So just the model to tell you, it's a fully integrated approach. You have a base mission hospital and a multidisciplinary palliative care team. And then in the next yellow box, you have all the things that goes on in the hospital, both inpatient care and outpatient care, inpatient care, symptom control, terminal care, respite care, and the outpatient care. We have some combined clinics, support groups, and also daycare procedures. And if they are within 25 kilometers, we offer home care, and if they want it, we provide that, and they see the same nurses and doctors coming there. So there is a lot of satisfaction because of continuity of care. Then if they are more than 25 kilometers, we tie up with a local GP or a nurse or anybody who is willing to help and do what we call as remote supervised care. And then after the death of the person, for the family, we provide bereavement support. And this is a good time also to provide health education, cancer prevention for cancer, and also behavior change in the context of HIV/AIDS. So the plan for this afternoon, I would like to touch upon some of these basic things, basics of palliative care, continuum of care, and transitions as the person moves from one stage to another, the role of communications in all these, building a relationship of trust, the importance of Genogram and the family conference, the certain skills that we need, like breaking bad news, therapeutic dialogue, and advanced care planning. Also, palliative care is holistic care. Spiritual support is an important aspect of palliative care, but it is often not performed, not done. And so I'd like to touch upon that. Critical communications, especially when the person is in the dying stage, actively dying or end of life, what we say. And then communications within the team itself, with the professionals, and also with the community. And I also want to touch upon anticipatory grief and bereavement support. This picture is of Dame Cicely Saunders. She is the pioneer of the modern hospice movement. And you can see that in 1967, she started the first hospice, St. Christopher's Hospice in London. She started her career as a social worker, but then she wanted to do more hands-on help. So she trained to become a nurse. And while doing this, she started to develop some back problems, and she just couldn't continue to be a nurse. So she went back to being a social worker. And it was one of the senior doctors who saw her interest that he told her, Cicely, why don't you train to be a doctor? And you know what he said? He said, it is the doctors who desert the dying. So nurses, you are all there with the patients all the time. And it is nice to know that this pioneer was a nurse once upon a time. And this picture on the right, and this statement here by Dame Cicely Saunders, it kind of summarizes and tells you what palliative care is all about. In this picture with Dame Cicely Saunders sitting there next to the patient, you can see that the patient is towering over her. The patient is in full control. She's comfortable, and comfortable with a multicolored cover and giving people control. She seems to be in full control, full confidence, giving people control, keeping them comfortable till the last breath. That is palliative care. And look at this statement by Dame Cicely Saunders. You matter because you are you. You matter till the last moment of your life. And we will do all we can to not only help you die peacefully, but to live until you die. A very honest statement, a brave statement, a statement of commitment, a statement of assurance and hope for the person and family. So it was my special privilege to meet her in 1996, just a year after we started our program, and she was able to spare nearly 45 minutes, and she was so interested to know what was happening and also to encourage me. So, talking about what is palliative care, and a very simple way of looking at it is holistic care of people facing a life-limiting illness to improve their quality of life, not only quality of life, but also quality of death. And it is not just the person, but also the family, because both of them are suffering and we need to help the families to cope. And you can see WHO, this was the first definition WHO came out in 1990. And as I told you earlier, Dame Cicely Saunders started the first hospice in 1967. So nearly 2 decades, more than 2 decades after that is when WHO really realized that this is an important aspect of care that is missing in our healthcare. And so they came up with this definition that it is active, total care of patient and the family when the disease is no more responsive to curative treatment. Then they modified this definition again in 2002. And in the Lancet Commission in 2017, they also added the word serious health-related suffering. So according to this definition of 2002, palliative care is an approach that improves the quality of life of patients and their families facing the problem associated with life-threatening illness through the prevention and relief of suffering. Here is a medical definition which is first time talking about suffering, relief of suffering by means of early identification, impeccable assessment, and treatment of pain and other problems, psychological, physical, psychological, and spiritual. So what are the conditions which require palliative care? One is incurable cancer, and the other is end-stage chronic medical diseases, all your cardiac, resistant cardiac failures, COPD, end-stage renal disease, HIV, AIDS, and advanced neurological disease. Also, people who need long-term care, paraplegics, people who have fallen off building sites, construction sites, or who have had young people who have had a motorbike accident and are paraplegic, or congenital progressive diseases. Also, another big group, which is in future, which will be the biggest group which needs palliative care, are the elderly with physical and cognitive frailty, and then also serious health-related suffering. The cry of those facing a life-limiting illness is the same. Whatever the disease which is causing, the cry of people who are facing a life-limiting illness is the same. They all need help to begin with. A lot of help they need. And so we can provide that with a multidisciplinary team so that all aspects are looked into. And then when they're feeling better, they want to share their life story. They want to talk about their highs. They want to talk about their lows. They want to talk about their fears. They want to talk about their concerns. So we need to be there to be listening to them. And also the later when they are further weakened, they are unable to even smile. So we just need to be with them for a while and stay with them for a while. And after they are gone, the best way we can honor them is to remember them and to learn what valuable lessons they have taught, especially families who have done everything to look after their loved one. So we can learn a lot and become better human beings ourselves. Here's a famous theologian who says, God whispers to us in our pleasures, speaks in our conscience, but shouts in our pains. It is his megaphone to rouse a deaf world. Yes, the point is, are we listening? The magnitude of suffering in India because of very less involvement and availability of palliative care, less than 5%. So you can understand the magnitude of suffering and the cry and the shouts of pain. So, well, what is the need for palliative care? Based on population-based estimates, about 60% of all deaths need palliative care. So it is such an important aspect of healthcare, which is often overlooked. And not only overlooked, it can also become inappropriate in these terms, as it is mentioned here by the Human Rights Council, which says denial of pain treatment is a form of abuse in healthcare settings that may tantamount to torture or cruel, inhuman, or degrading treatment or punishment. Yes, if a person who's nearing the end doesn't need to be in ICU, does not need to be on a ventilator, then it is very inappropriate that it is done, and it is a form of abuse amounting to torture. This is an important diagram. I want to take some time telling about this. This tells you about the continuum of care, continuum of palliative care also. So when we look at the extreme box on the left, it's a pink box, and it is preventive care and healthy lifestyle. Everything is going on well, but let's say something happens, you break a bone, or you have a myocardial infarction, and you need curative treatment, which is often followed by rehabilitation. But let's say you have a diagnosis, unfortunately, of a terminal illness, of a life-limiting illness. Then, according to WHO, palliative care must come in early as possible, even when modalities are going on, even when rehabilitation is going on. But as time goes on, curative intent, restorative intent, rehabilitation becomes less and less, and palliative care is then what occupies center stage. And as time goes on, you can intervene here, at the time of diagnosis, but this rarely happens. So the next point you may intervene is when we can identify people who are approaching the end of life. Approaching end of life, and according to the Gold Standards Framework, GSF, or the NICE guidelines, or GMC, General Medical Council in the UK, they take up it as about a year, and maybe 6 months here in our situation, or even last month of their stay in ICU. And then we move into the last 48, 72 hours, the phase of actively dying. And this is where we need the integrated care plan for the dying. And I'll tell you about the Project India of the International Collaboration a little later. And then after the death of the person, we have what we call bereavement care or bereavement support. And we will be looking at that. So the three essential components of palliative care is shown here in this equilateral triangle. In other words, all these aspects, symptom relief, psychosocial and spiritual support, teamwork and partnership, all these are equally important. And the common thread which keeps everything going, the common thread is communication. Without good communication, all these things will not be effective, they will fall apart. And then the aim of all this is to empower the patient and family to harness their potential. Everyone has given God-given potential to take care of themselves. God-given potential to the family to take care of their loved one. So by providing all this help and with good communication, we can empower them and harness that potential which is there so that they can cope with this difficult situation. So let us look at what is good death, because that is what we are aiming for, good quality of life and good death. And the principles are stated here: to know when death is coming and to understand what can be expected, to be able to retain control of what happens. As I said in that first picture, keeping people in control, that is what gives them dignity. And we have to have control over pain relief and other symptoms, because if they have a lot of pain and difficult symptoms, then they are not comfortable and they can't think of anything else. To have choice and control over where death occurs. Yes, where do they want to die? Do they want to die in a hospital ICU, or in a ward, or home? To have access to information and expertise of whatever kind is necessary, to have wishes respected, and have access to any special needs. Yes, this is very important, to have their wishes respected, to have control over who is present and who shares the end, to be able to leave when it is time to go, and not to have life prolonged pointlessly. So, that is the important role of communication then. What is the role of communication? Effective symptom control is impossible. You cannot do good symptom control without effective communication. The act of communication is an important part of therapy. For example, weakness or fatigue is a very difficult symptom, and you may not be able to do much about it. But when you explain that to the person and say why it is so, why they're low in energy, and how to modify their lifestyle to suit that limited energy, and how to do things to conserve that limited energy, that is part of therapy. They're able to cope. Usually this requires thought and planning. Communication requires a lot of thought and planning. And unfortunately, it is commonly administered in subtherapeutic doses. The good news is that these skills can be learned and improved with practice. So the aims of communication in palliative care is to reduce uncertainty. There is a lot of things happening. Suddenly life has changed. And we say uncertainty kills a person. Yes, so good communication helps to reduce that uncertainty. It helps to enhance relationships. It helps to build a relationship of trust, which is very important. And it gives the patient and family a direction in which to move. And so the three important areas are, first of all, basic listening skills. We have to be good listeners, not suddenly jump with solutions for whatever they are talking about, the problems. God has given us 2 ears and and one mouth. So we have to be better listeners. But we also need to help them with good communication, with talking. Specific communication tasks we need to learn. One is breaking bad news. The other is therapeutic dialogue, telling them all, answering all their questions about their treatment and what to expect, complications, everything. Talking about that therapeutic dialogue. And then critical communications, especially when you're reaching the phase of dying. This suddenly it is a bubbling situation. A lot of difficulty for the family to cope. Even though they know that the person is going to die, when it actually begins to happen, it is a critical situation and it's very difficult. And then good communication will help that. So communication, and then you have communication within the team as well, and other professionals and community. So we need to understand the family. We need to know the family dynamics. And this is for the whole team, not just the doctor or nurse, so that the social worker, the counselor, everybody can quickly understand the dynamics of the family. And therefore, we have what we call a genogram or a family tree. And these are the symbols in that. That is, the square one is man, and the dead square is a person who's died. Round circle is woman, and then black dot is dead. The patient is marked as a cross in that, and the caregiver, main caregiver, or you can loop them together, is shown as a tick. This is the married situation. If they are separated, it's one line. If it is divorced, it is 2 lines. And then we have some more symbols. If they are cohabiting, then it is a dotted line. If it's a homosexual relationship, then it is shown here. And then sometimes it is second and third marriages. So you can see here the first wife divorced. And then the person married again, but the second wife died. And then you have the third wife. The parents are kept in one line, and then the children are kept in the second line. And you can see twins are shown like this, and pregnancy is shown like a circle with a dotted line. Genogram is important because it's a pictorial representation of the family. It is helpful for all the team, and it serves useful functions, many useful functions. It records useful family information, and we say in palliative care, it is more important than a stethoscope. It is useful because it can show what support the person has. It can show who's the caregiver or who are the nearest caregivers. It can show us insight of the family members. Sometimes the family would have gone through a death by themselves, and death due to cancer or something else. So they have some insight into that. And sometimes their perception of pain themselves is colored by that experience in the past. So it helps us to know all that. Children's insight, previous deaths in the family, other family worries, unfinished emotional business, expectations. So all these can be recorded briefly in that genogram. And so it's a very useful tool. And we can use this effectively when we have the family conference. Again, family conference is a very important tool in palliative care, where we bring in all the important decision makers in the family. Because in India, we need to take the family along with us. Especially in the context of breaking bad news. The family, the first thing they will say is, no, please don't tell the person. So we need to bring them all together, and then maybe you can start writing on the board. You can start making a genogram. They're all sitting very quiet, nobody's saying anything. Then you marry off somebody with somebody else, and then suddenly they wake up and say, no, he's not married to that person. And so then they begin talking. And then slowly you're able to influence one person at a time. And then that person begins to influence the others. And finally, they may agree to breaking the news to their loved one. Let's just read through this nice statement. Communications, like tumors, may be benign or malignant. They may also be invasive, and the effects of bad communication with the patient may metastasize to the family. truth is one of the most powerful therapeutic agents available to us, but we still need to develop a proper understanding of its clinical pharmacology and to recognize optimum timing and dosage in its use. Similarly, we need to understand the closely related metabolisms of hope and denial. Very nice statement, kind of comprehensive, helping us to understand how important good communication is. Another statement about truth telling. Truth, like medicine, can be intelligently used, respecting its potential to help and to harm. So, if you do it not in an inappropriate way, it can also cause harm. So, one of the important things in palliative care is breaking bad news. Bad news is any information that drastically alters a patient's view of their future for the worse. It is a process that resembles holding a negotiation. Negotiation is needed because a patient has a right, but not a duty to hear bad news. The patient has a right to know this, but not necessarily a duty to hear it. So we don't have to unload it on them. We have to take it according to his pace or her pace and give it according to how much they are ready to hear. Breaking bad news is an important skill for all of us in healthcare, for doctors and nurses, and education about this basic principle often remains minimal. So, why is breaking bad news difficult? We all feel incompetent. We don't know what to say. We feel that we may get blamed, or the patient may get angry, or the family may get angry with us, or the patient may start weeping or crying or shouting, and so we are not prepared to handle those reactions. We feel a failure because in our usual medical training, we are taught to cure. But when cure is not there, we feel a failure. So the other thing is we want to shield the patient from further distress. And this is exactly what the family also is doing. When they say don't tell the person, what they're saying is don't hurt that person. They're doing it out of love, and we must acknowledge that and appreciate that. Feeling awkward about showing sympathy, we want to be stoic and just listen and be very matter-of-fact kind of thing. Being powerless to control emotional distress, feeling embarrassed about how to behave, and also not enough time. This is a very common kind of excuse we have. And also we are reminded of our own human vulnerability to illness. So it is because of all these reasons we shy away from learning how to do this important task. And the good news is it is professionally satisfying to develop competence in dealing with emotional elements of illness. So when we develop competence in breaking bad news, you will realize that you are helping people and it will be professionally satisfying. Why is breaking bad news important? It is important to maintain trust. Often the family keeps on telling the person, oh, there's nothing to worry. The doctor said there's some infection there and it'll become all right. So in this one, some weeks go by, a month has gone by, a few months go by, and then the person begins to, because he knows he's not getting better, and he begins to lose trust in his family. So not only in his family, but also in the doctors, in the nurses who are taking care of him. So we need to reduce, breaking bad news helps to reduce that uncertainty. It helps to prevent unnecessary and inappropriate hope. It allows us to have proper, appropriate hope, practical and emotional hope, and good adjustments. It helps us to prevent a conspiracy of silence. The patient is alone on one side, and there is a wall in between, and the family is on the other side. And there is a conspiracy of silence. So that has to be broken. It is often the first step in meeting the person's expectations. The person is going through a difficult time, and he has a lot of expectations. So unless we are truthful and we are able to help him with good, proper way of breaking bad news, so then that is the first step in him meeting his, coping with his crisis, and it is the first step in his expectations. So breaking bad news is essential to maintain trusting relationships. Let's read this statement here. A young couple had a first child who had developed a brain tumor at the age of 2. They were shocked and distressed and asked for a second opinion. After talking for an hour to the consultant, the second consultant, the husband commented, "You have only told us what the other doctor said, but somehow it doesn't seem so bad." See, this is the first step in helping them to start coping with this terrible situation that they are facing. So the patient's expectation is he wants a certain information. He doesn't want he wants the right amount of information. He wants the opportunity to talk and think about his situation. In other words, he wants a therapeutic dialogue, and that is what we can provide to the person. For certain do's, we need to ask questions about the question. In other words, what we call reflective listening. Sometimes, the doctor would have talked about the diagnosis and all, but when you as a nurse, you are attending to the person, and sometimes when you're alone with the person, he may hold your hand and say, "Sister, do you think I'm dying?" So these difficult questions you may have to answer. And one way of doing it is to ask question about the question. You can ask the person, "Why are you asking me this question?" And if you know, you can be truthful about it and mention it in the way that you have learned as to how to break bad news. But on the other hand, depending on the policy of your setup, you can say, "I will find out, I will get the doctor to talk to you." In other words, you're being an advocate for the patient and to get the information that they need, and you will provide it for them. So in other words, it is possible to explore concerns. You can talk a little bit with the person, but you may not necessarily give the full information, but you can explore concerns. You can help them to ventilate their feelings. So for breaking bad news, it's usually done in a workshop, and so we won't spend time here today. It's not possible. But there are two approaches that I am familiar with. One is the 10 steps approach by Dr. Peter Kay, and these steps includes preparation. Preparation includes knowing everything about the patient, knowing about the genogram, knowing about the treatments he's had, and knowing about where you want the family to, this breaking bad news to happen, who is going to be present. So all this part of preparation. And then how much does the patient know? Does he want more information? Giving a warning shot. In other words, you are slowly going to have, breaking bad news is a blow, but you're softening that blow. You're saying that the X-ray has a shadow. The shadow doesn't look good. It's not a usual shadow. It's an abnormal shadow, like that. And you give time for the person to ask questions. You allow denial. When suddenly they have become quiet, you stop and you take it at the pace that they want. You explain whatever questions they have. You listen to their concerns. You encourage them to ventilate their feelings. When they start crying or anything, you stop further conversation. And at the end of it, you summarize and make a plan as to when you can meet again, and also offer availability. Anytime that they want to talk to you, you can give them your details. And the same thing is given in the Spikes protocol here, and all this can be dealt with in a workshop. So we won't spend time there, but that's the acronym for that, and it almost covers the same things that the 10-step does. So therapeutic dialogue, advanced care planning. The patient, it's important for them for us, as we are helping them to explore their understanding of their illness, to explore their wishes, explore what their unfinished businesses are, and see how we can help that. We need to allay their fears, and also we need to respond to their concerns. We need to facilitate frank and frequent conversations within family. Not that he's all alone in a single room and nobody is talking to him. Everybody is not wanting to, face the truth and tell him. So we need to facilitate frank and frequent conversations, explaining all details of their treatment, answering their queries about their treatment, and be truthful in all dealings, giving priority to the person. And as I said earlier, providing spiritual support is an integral part of palliative care. And this is often overlooked. And I just like to touch upon it. We can do it in the form of what we call a spiritual dialogue. And the important areas that we can talk about is, first of all, relationships. We can ask them, do they have faith in God? Is that very important for them in their life? What is their relationship with the family? Do they have any broken relationship? Because sometimes mending that relationship brings a lot of peace for them. Is there a need to be forgiven or to forgive? Then we can look at the values. We can tell them, what are the values which are dear to you? What are the values you want to pass on to your family and to your friends? You can talk about meaning. What gives you meaning and purpose in life? We can ask them to share some meaningful moments in their life, some happy moments, some not so happy moments, some difficult moments. So it helps them to ventilate and talk about all these things. We can talk about hope. What is your hope? What gives you hope? Do they believe in afterlife? What gives you peace? Do you have peace? So in this way, we can, make a spiritual dialogue with them, and we can also do some specific interventions. But all this only, and I emphasize, only with their permission. With their permission, you can share your personal feelings, your stories, your testimony. You can share a scripture verse, either from your faith or from their faith as appropriate. And always you can, with their permission, you can pray for them. So it's important for us to know when a person is dying. So the important things are, they're unable to swallow medication. They're managing only sips of fluid orally. They're withdrawing from food and drink. They're withdrawing from surrounding. In other words, they're not smiling at you or showing any recognition. They're profoundly weak. They're sleeping most of the time. They're semi-conscious or unconscious. One of the things that bothers families is the noisy breathing or death rattle. And you can explain to them that, it is because they have become so weak that they cannot swallow their own saliva. And because of that, it pools in the back of their throat. And when they are breathing, when air moves over this collected pool, it creates that sound. So the person is not suffering, but it creates a bad sound. And also progressive multi-organ failure. So in all these things, you have to then modify your communications to address these kind of transitions. So one important aspect in end of life is establishing consensus between the professionals and consensus within the family, because one person may say, I understand what the doctors are saying, but another person or a phone call from UK or USA may say, no, do everything, So then you need a consensus. So you have to work hard on that, providing accurate and appropriate information which will facilitate further decision-making, eliciting resolving the concerns that these end-of-life decisions may bring up, establishing trust, a therapeutic bond, and facilitating realistic hope in an adverse situation. And then, we also need continue the same thing with the family, communicating and teaching family. We said, no, to empower them. So to empower them, we need to make sure that we have taught them all the skills that we have. We have to teach them. We have to empower them because they are the ones who are going to be there 24/7. And so if they are empowered, then we have won the battle. To achieve consensus with family, and we need to document it within teams so that all efforts are coordinated, so that everybody, all the doctors, nurses, professionals, everybody, we are on the same page and we are saying the same thing. And again, with other professional colleagues, and that's what I said, we need to have a professional consensus. And then community is an important part. And we need to see how we can talk to some relatives who come to see them or other family and friends who come to see them. We can communicate with them also. And then this is an important aspect of empowering the patient. And this is something we have done in Baptist Hospital, because in the end stages, the patient is unable to swallow. So how will he get the necessary medicines? Opioids, and also some of the medicine for breathlessness or for agitation or for nausea, vomiting. So all these medicines in the US and UK, they have either in the hospital, they have what we call syringe pumps, which you are all familiar with, or they may have at home, in the home care, they have something called the syringe driver. But these are not practical in our Indian situations in our home care. So what we have is we teach the family and we give them the same 10 ml syringe which is used on a syringe driver, and tell the family we use the same combination of medicines, and tell the family to inject 1 ml of this combination every 4 hours, because morphine acts for only 4 hours. And just like the oral method, we tell them to inject 1 ml every 4 hours and in between as needed. And with that, you can see that all this is happening the same visit. The family, the lady in the blue there, and that is her family, and she's being taught by the nurse. And then in the same visit, the family is made to do. And then, you can see the result that she is comfortable and happy. So all this can happen within a visit or 2 visits, and we can follow it up. So as I said, community is very important because many of the problems in advanced disease are of a non-medical nature. And so the community has a major role to play in addressing these problems. You can see here, only the yellow or the orange thing here is the physical part, which doctors and nurses are involved with. But the community can help in all the other aspects, in financial, social, psychological, spiritual, all these aspects, the community can help. So it's important to communicate with the family also. There's another statement by Dame Cicely Saunders. She said, how people die remains in the memory of those who live on. Yes, one person is dying, but 4 or 5 family members are affected. And if it's a bad death, then these family members, their memory, it remains in their memory, and they are affected for life. They themselves need psychiatric help. Instead of being resources in the community to help others, they themselves become liabilities, and they themselves need help. So it is very important that we achieve a good death. And then we have something called anticipatory grief. In other words, even when the person is alive, we can help him to reassure him. So anticipatory grief helps to reassure people, and we can address his concerns. It helps to facilitate expressions of goodbyes. It helps in promoting peace. It helps in honoring their wishes, and helps the family to keep all this in mind. And here we can see a counselor here doing anticipatory grief, trying to reassure and help the person even before his death. And then finally, we have what we call bereavement support. And we know that Dr. Elizabeth Kubler-Ross, a Swiss-American psychiatrist who developed those 5 stages of grief, and in her book on death and dying, she emphasized this. And this will help us also to help families to work through their grief and to help them to remain functional and cope with the loss. The same people can be used as resource people. And this is, as I said, bereavement support is also an opportunity to provide health education. And you can see here the grief cycle. Initially, you have protest, then there is disorganization, reorganization, and then life takes on a new meaning. So in conclusion, I would like to say that good communication is therapeutic. Communication is important to build a relationship of trust. It is often the first step in helping the person and family to cope. It is important throughout for effectiveness of our care. And basic principles can be learned and improved with practice. Empathetic communication is integral to compassionate care. And spiritual support, we need to remember, is often overlooked. So we need to become good at it. And again, simulation methodology is very useful for rapidly building capacity of caregivers and good communication skills. And I am So happy that we in Baptist Hospital have this simulation facility, and we are grateful to Professor Shelby Garner for making this facility available. So thank you very much. And I just have a small last words, 3-4 minutes video, and we can stop at any time. But I will just stop with that, and you can stop with that.
Mrs. Raksha Mehta, a very lovely person. Last Wednesday, my special salt tanta. I love you, Michael. Mrs. Dash ने मुझसे कहा क्योंकि मिस्टर Dash नहीं थे वहाँ, इसलिए मुझसे कहा. She gave me this recipe to give to a family.
साठी ना હતા મિસ્ટર અગરવાલ સડન હાર્ટ એટેક થી એડમિટ થયા અને સન અમેરિકામાં હતા.
Mr. Coates, middle-aged, very jovial Bengali fellow. All of a sudden he became very serious.
મારા બેટા આયા, મારા દીકરા આવી ગયા, એના સના લાસ્ટ વર્ડ હતા બસ.
And he said, Aman make a bold way, Aman make a bold way. Tell my daughter I approve of her choice.
एक छोटा लड़का था शायद 8 साल का, उससे भी कम. उसके लास्ट वर्डिंग थे मम्मी को बाय बोल.
Shamina, उसने मुझे से कहा
7 वर्षाच्या त्रिपाठी बाई मला जाताना सांगून गेल्या श्रीकृष्णांची आखरी शब्द मोडा सांभाळ.
अंधेरे से मुझे बहुत डर लगा.
माझ्या नवऱ्याला सांगा मुलांची आणि स्वतःची काळजी घ्यायला, कारण त्यांची काळजी घेणारे मागे कोणी नाही.
उनके लास्ट वर्ड थे सॉरी, बस सॉरी, सॉरी.
मिस्टर अय्यरचे शेवटचे शब्द होते, कधी कोणाला तुम्ही जाताना पाहिलं का?
Thank you.
I think sir left the meeting by mistake.
Yes, ma'am. Sir will join.
It's okay, you can go ahead.
Yes. Thank you, sir, for your enlightening talk and highlighting us on how important is communication during palliation. It was very helpful for our young nurses to communicate, that is, how best they can communicate with their family members and the caretakers about this palliative care. Thank you so much. Let me now introduce our next renowned speaker for today's session, Shelby Ma'am, Associate Professor, Baylor University, Lewis Harrington School of Nursing, Dallas, Texas, USA. Ma'am's primary interest is research involving building nurses and health system capacity globally through adaptation, design, and testing of innovative technologies to transform health education and improve patient care. These technologies include healthcare simulation and mobile health resources. Ma'am has also worked with long-standing partners at Bangalore Baptist Hospital for the last 10 years on a variety of research and capacity building projects. It's our pleasure to wholeheartedly welcome you, ma'am, for the webinar and deliver the talk on the topic, Crucial Conversations and Simulation at Healthcare Settings. Over to you, ma'am.
Thank you so much. Can everyone see my screen okay?
Yes, ma'am, we are able to see.
Okay, great. I just wanted to make sure. It's a little bit of my first time using the Google Meets, so I hope that you guys are patient with me. First, let me just say thank you. I want to say thank you to Dr. Stanley for the presentation that I was just able to sit in on, and all of those important things that are so critical to the palliative care patient. Second, I want to say thank you to Lena for inviting me and for hosting this webinar. This is such an important topic, and she did such an amazing job in her dissertation work on this topic. So thank you so much for inviting me. So yes, my topic is crucial conversations in healthcare simulation. And what I'm going to do is kind of give an overview. We'll then talk about when communication fails, and then some strategies, particularly with simulation, that we can do to improve communication, and then evaluation methods for that. So the overview, when are crucial conversations most needed in healthcare? I know that this is something that you've talked about in the previous sessions, and we just heard the important context of the patient situation. But what I want to cover is also some important aspects of the interprofessional communication between the nurse and the nurse, between the nurse and the physician, and between the nurse and the healthcare team, as well as between the nurse and the patient or family members. So the very first thing I want to show is a video. When you're thinking about this video, I want you to think about putting yourself in the place of the audience. So as a health provider working in a pediatric emergency room, let's say that you want to improve the quality of care for patients and families who serve in the department. You attend a talk given by a mother who lost her daughter as a result of improper breakdowns in communications, and you would like to implement a policy in your department to be sure this breakdown does not occur in your health system. And so I'll play the video now.
Ma'am, sorry to interrupt, ma'am. Hello, ma'am. Yes. Ma'am, the audio is not there, ma'am.
Oh, the audio is not coming through.
Yes.
Okay, so what I'll do is I'll go ahead and just kind of do a recap. I'm not sure why the audio, it's coming through on my computer. I'm not sure why it's not coming through on your computer, but I'll do a recap of the story. So thank you for letting me know. With this particular true event, this is when Josie King, a child, was admitted to one of the most famous and most highly respected hospitals in the world, Johns Hopkins Hospital. She was in the pediatric ICU, where her family said she received exceptional care. She was admitted with burns, accidental burns associated with a bathwater that was too hot. She received excellent care and was transferred then to a less acute area, more of a general unit. and her central line was DC'd before she was sent to the general unit. And I'll hope that maybe as we share these slides, you can go back and listen to this actual story because it's very powerful. So when she's receiving care on the floor, the mom is with her continuously. She stays by her side. And she notices that Josie is very thirsty, but the nurses insisted that she was NPO. Josie was receiving a lot of pain medication, and the mom starts noticing that she has changes in her affect. She's more lethargic. She points out at every single time the nurse comes in the changes that she sees in Josie's condition. However, the nurses continue to say that these changes are normal. Finally, the physician tells Josie, and the nurses reassure or Josie's mom, that it's okay for her to go home for a few hours and get some rest and come back. And so she does that. And when she comes back, she notices a severe change in her daughter. Again, she brings this to the attention of the nurses, who again say this is normal. And when Josie finally suffers, she has a code and is sent back to the ICU. She is put on a mechanical ventilator, and eventually that has to be turned off, and Josie died. There are several things that led to this tragedy, and the breakdown in communication was the number one thing that was identified as leading to Josie's death. So how did communication breakdowns occur? We know that they occurred between nurses and nurses in Josie's case. They also occurred between nurses and physicians, nurses and other members of the healthcare team, and nurses and the patient, and nurses and the family. And so nurses, as we know, are integral to the communication cycle and to the healthcare team. How did they break down, the communication breakdown between nurses and nurses? We know as nurses were giving report to each other in Josie's case that there was not good communication about her central line being DC'd, and there were not good reports of assessment. Of course, Josie was suffering from severe dehydration that was complicated by the pain medication that she was receiving that also caused dehydration. And without the IV fluids that had been stopped, and without her, with her NPO order that she had, Josie was actually, without fluids and became severely dehydrated, which contributed to her death. The communication between nurses and physicians. The nurses and physicians were not communicating with each other, again, about Josie's assessment and her plan of care. No one had picked up on these crucial points. And the rest of the healthcare team, because there were many people that came into Josie's room and could have noticed some of the key assessments changes in Josie. The nurse not communicating with the patient herself, even though she was a child. And then most importantly, we know that families are key in identifying changes. They're usually by the patient's bedside for many hours of the day. And when they say something about a change assessment, it should send up what we call a red flag. And it should really, that should be something that we always pay attention to, even if we think what they're saying is normal or expected. If it's a change that they see, we should always pay attention to that and do a double check with our assessments. So this was just one example of when communication fails, and it can have a very tragic outcome. So what I wanted to focus on today is how we can use simulation strategies and methods to improve communication, particularly between the healthcare team. There's a few research articles that I want to bring to light. The first one is a systematic review and a meta-analysis. It was published in 2020 in Nurse Education Today. And this was a systematic review of 11 studies where they looked at what we call collaborative competence. And collaborative competence includes many factors. It includes communication, which is the subject we're talking about today. But we know communication is multi-level, and it also really expands into many other actions, such as collaborations, roles and responsibilities of the whole healthcare team, how they collaborate with the patient and the family. It expands into conflict management, teamwork, sense of professional identity, leadership, and avoiding errors. And so this study found that in 7 studies, there were significant differences or improvements among participants concerning these collaborative competencies after participation in interprofessional simulation activities. The second study that I'll bring to light is also a systematic review. We know that systematic reviews are excellent for us to look at to really see a compilation of studies and research. And so this systematic review focused on incorporating assertive communication and training evaluation. And again, it had 11 studies. And it found that face-to-face and multi-method programs that supported teamwork skills training were particularly effective. And again, using simulation that was adapted from the aviation industry, they were the first ones to use simulation. And we adapted many of our communication techniques from the aviation industry. And this found that behavioral change as a result of assertiveness interventions was evaluated by observer-based rating scales during the simulation, which is something we can do as instructors as we observe simulations by our students. So the next strategy that I wanted to talk about was developed by someone at my university. Her name is Jeannie Carey, and she's the director of simulation at Baylor University. And this is called Two Heads Are Better Than One. Now, any of you that have had the opportunity to participate in simulation or observe in simulation, you may have noticed that it really puts you on the spot, or it puts students on the spot. And so sometimes the nerves associated with that can be overwhelming, and then students don't perform to the best of their ability. Simulation should be a safe place to perfect clinical decision-making and nursing skills, and we don't want it to be an intimidating or scary place. And so the two heads are better than one has been an effective strategy in helping students to work together as one nurse. And so this is how it works. 2 students pretend or simulate being one nurse rather than being an independent nurse. And this allows them to talk to each other to decide what their next move is going to be together. So it also really helps with critical thinking. It helps the students, go through that dialogue with each other so that they can determine what is the best next action. So they're communicating with each other to determine maybe the best communication method with the patient. And so it's been something that has been effective, and Jeannie has done some research on this, but each pair moves as one person, so they can't be in 2 places at one time. They can't say one is going to get meds and the other is going to stay and watch the patient. They have to move together. You may perform multiple tasks in the same location, but they need to prioritize patient needs, and that's a big part of their communication when they're working in the sim lab, when we use the two heads are better than one technique. The theoretical basis for two heads are better than one, there is a quote by C.S. Lewis that says 2 heads are better than one, not because either is infallible, but because they are unlikely to go wrong in the same direction. This is what we call collaborative cognition. There's research theory behind this that when 2 individuals combine sensory information, the resulting actions are often better than either individual could perform alone. And so this is just a slide that shows a little bit about how simulation works at my school, the Baylor University Louise Harrington School of Nursing. We are very careful to always include interprofessional collaboration, which is, again, part of that collaborative competence and part of our simulation working together as a team to communicate with the whole healthcare team. And so we'll have the charge nurse. We have a control room, just like if any of you have seen the sim lab at BBH also has a control room. And we have a patient scenario, and then we have our nurse 1 and nurse 2, and there may be some other people We generally have what we call sim ops, and that's one of the nursing instructors who serves as like a pharmacy tech or a sim facilitator. And then we'll have the clinical faculty also in the control room who would serve as the charge nurse. We, of course, have the simulator where the scenario that's going on. And then we may have many other students in another room observing. That could be the control room, but many times what we do is we live stream it into a classroom so that it's not just the two nurses that are learning from the experience, but everyone who's watching it can also learn from the experience. So I have a couple of video examples. Since the audio is not working, I'm still going to play them, and I will just go ahead and narrate so that you kind of know a little bit about what's going on in the videos. So here we have two students who are let me just verify with you guys. So you're still not able to hear, is that correct? So in this video, the two nurses are doing an assessment on a child, and then we have a third person who's serving as the family member. Now, she has scrubs on, but she's serving as the family member. And in this video, the patient is post-surgical and having pain, but the nurses also notice that he has a rash. And so they're trying to ask crucial questions about how long the rash has been here. And meanwhile, the patient is more concerned with the pain. And so what happens in this scenario is that many times the
Kindly request all the delegates to wait. I think by mistake, because of net.
Mistake, she has left.
Yeah, ma'am has left.
Network
I think.
issues.
Because
She'll come
of
back.
net.
She'll come back.
Yes, ma'am, sure. Meanwhile, delegates, if any queries from your end, kindly put it in the chat box.
So, dear delegates, thank you for your patience. Meanwhile, as Shilvi ma'am will be soon connecting with us, I have shared a YouTube link in the chat box. So this is for your reference, like in future, whenever you want to come back to the contents, you would like to refresh your knowledge about the healthcare communication skills, you can always use this link and refresh your knowledge related to the communication skills.
You only did in pro.
Okay, are you able to see my screen?
Yes. Yes.
Okay.
Yes, ma'am.
Okay, I apologize. I didn't know because it shows my whole screen, so I did not know that it had disconnected.
No issues.
Some questions.
Okay, let me just cover a few more things and then I'll open up for questions. So I went through the videos. I'm going to go ahead and go to the next slide and talk a little bit about evaluation. And am I correct? This is where it disconnected? Lena, am I still on?
Yes, yes, I'm seeing the screen. The last slide that we all saw was the simulation scene.
Okay, so now you see evaluation?
Oh, yeah.
Okay, great. So evaluation, which is very important in simulation, can be done in a variety of ways. Evaluation includes observation. This could include the instructor either in the control room, watching the students practice more independently in the sim lab, or it could be the instructor in the same room taking notes. And then talking this through with the student in a debriefing after the simulation. Another very effective form of evaluation is to do video debriefing. And video debriefing allows for the students to sit and watch any of their own mistakes and then to talk through how they could improve those. It's very important with both observation and video debriefing that we never impugn the student. We want the student to always have a positive experience and not to feel shamed at all in the simulation lab. And so these techniques should only be used to help the student identify ways that they could more positively impact their communication or whatever clinical decision-making skill that we're evaluating at the time. And then there are a variety of evaluation tools that you can look up online. The 2 systematic reviews that I just provided you the citations for, those also are good tools. They have in them many studies that have excellent tools for evaluation if you wanted to use a more formal tool for evaluation. So before I open it up for questions, I do want to apologize that I had some technical difficulties. I also want to say a thank you. I ended the presentation with the Texas Bluebonnet. So I'm coming to you from Texas, and I know it's late afternoon for you all, but it's very early morning for me. I want to give everyone an opportunity because simulation may be something that you are or are not doing at your facility. So I want to give everybody an opportunity to ask questions and us to have a little bit of dialogue about simulation and how you might be able to use this going forward.
Yeah.
Thank you, ma'am. Delegates, if you have any questions or anything to be clarified from ma'am, this is the time. Mr. Ranganath, is there anything?
First is forum. Post test forum, sir.
I'll send that. I'll send the link in the chat box. But if you have any questions related to the crucial conversation, you can ask.
No, sir. No, sir. Thank you. Thank you. Okay, sir. Okay.
And I'll ask Lena, ma'am, to please send out the presentation so that you all can view the links and see the videos that were embedded, because those are powerful points to really show how communication can break down and can fail, and how we can do a better job with our interprofessional communication. Thank you.
Thank you, ma'am. Thank you for such an enlightening presentation on the crucial conversation. I'm sure it was very much beneficial for all the participants, the young nurses who are listening to you. And I think it was a great message to the nursing institutions as well as the nursing leaders to inculcate the concept of crucial conversation in the sim labs as well, wherein we can handhold the students and teach them how to tackle a situation where they are going to come across crucial conversations. Many may not be aware of the technical term crucial conversation, but I think this was a good opportunity to know what exactly is crucial conversation and how important it is for a nurse to be aware of that. So thank you so much, Shelby ma'am. It was really a very delightful session. Moving further, thank you, ma'am. So moving further, so we are now inching towards the end of the webinar, of the 2 days webinar on health communication skills for nurses. Now it is time to listen to Dr. Dayanand. He is the Director of Advanced Research in Rajiv Gandhi University of Health Sciences. I request Dr. Dayanand to come forward and deliver the closing remarks. Over to you, Dayanand, sir.
Hello, I'm sorry, I'm from Dr. Dayanand's office. I'm his assistant. He's in another meeting. He'll join you by another 5 minutes, sir.
No issue, sir.
He'll get back to you in another 5 minutes.
Okay, sir.
Yeah.
So dear delegates, I'll be sharing the feedback link in the chat box. In the meanwhile, kindly fill up the feedback link. I've shared the feedback link in the chat box.
Shall I use this
few minutes to
talk to the delegates? I know at least few of them from other colleges are here.
Yes.
You all know that INC is, already, it's not rolled out, but they had oriented all the nursing colleges with a revised nursing, BSc nursing curriculum. They're also coming in a big way, or expecting the colleges to incorporate the simulation. At least have labs, and I know many of us do not have, because it comes with a very high cost to establish and also to maintain. We have a very good lab at Bangalore Baptist Hospital, and I take this opportunity to invite, for those of you who want to have at least an idea or even use it for your training purpose. So please feel free to come and visit us. And we have learned over this 5 years in prior to, when we didn't have, because it allows them to make mistakes and they learn and they do well. I think sir has joined us. Yeah.
Yes, ma'am. Sir, thank you, ma'am. Over to you, sir. We were eager to listen to your remarks.
Okay, very good afternoon to all of you. And we are happy to see that Rajiv Gandhi University of Health Sciences, along with RV College of Nursing, has organized the international webinar on health communication skills for nurses on yesterday and today for both the days. And also the communication is very important for every aspect of life, and especially the health workers like nurses or doctors or the lab technician, whoever it may be, because by communication itself, we can cure most of the patients by speaking, by talking, by counseling the people, is it not right? So I congratulate and compliment the RV College of Nursing for taking the initiative to conduct such a webinar, which is useful for for the undergraduate as well as the postgraduate students in nursing. And in these 2 days of webinar, and the many speakers that have spoken regarding the communication skills. For example, the significance of effective communication for healthcare workers by Mr. Sunny Kuruvilla, and need for integrated communication skills for undergraduate nursing by Dr. Lina Lordswamy, and the critical communication skills for palliative care patients and their families by Dr. Stanley McAdam. So I thank all of them, those who have spoken yesterday and today, and I wish all the best for the RV College, and I wish all the best for the UG students and PG students, and those who have participated in this webinar. And I take this opportunity to thank the organizers for giving me the opportunity to communicate with you in this webinar. Thank you.
Thank you, Dayanand sir. Now I request Dr. I. Clement sir to express the vote of thanks.
Very good evening to one and all, dear participants. And first, I thank the organizers, that is Rajiv Gandhi University of Health Sciences, RV College of Nursing, and Baptist College of Nursing. So these three organizations joined together. We have organized wonderful, very important and needy topic for the webinar. And there are very eminent speakers are delivered about the communication, because communication is very important and vital in nursing profession wherever we go. It's a globally very important topic. When I was discussing with Madam Dr. Lina, Madam has accepted and given her first concern, like, sir, we will do. This is very important and very basic things. Every nursing, BSc nursing, and even PG and all levels of nursing, they are very badly in need of this communication skills. And so we selected this topic. So especially the special thanks to Dr. Lina, given she selected this topic. Wonderful, very important.
Excuse me, sir. Audio is low, sir. Audio.
Continues. And second thing, like, I thank the Rajiv Gandhi University Vice Chancellor, Dr. Jaikar Shetty, Dr. Jaikara SM, Honorable Vice Chancellor, Rajiv Gandhi University, giving a continuous support for nursing, continuing nursing education webinars to be happening at Rajiv Gandhi University and other levels also. And unfortunately, sir was not delivered a inaugural address. And Dr. Ramchandra Reddy, Ramkrishna Reddy, registered Rajiv Gandhi University of Health Sciences. Sir has given an inaugural address, and sir has spoken about very important issues in communication skills applied in all levels of nursing. Next, I thank Dr. Ramuke, Faculty of Nursing, Principal RR College of Nursing. So he is giving a continuous encouragement support for organizing various education programs. Next, I thank Dr. Gajendra Singh, organizing chairperson, Principal RV College of Nursing. Sir has made this setup like all technological and all of our staff, RV staff, for continuous webinar. We happen to be at the university and college level also. So I take opportunity to thank Dr. Gajendra Singh sir. And next is Dr. Naveen Thomas, Director, CEO, Bangalore Baptist Hospital. So sir has given very important role and also sir has joined and discussed about the unfolding the theme. So I take opportunity to thank you, sir. And next, coming to the scientific section, Mr. Sunny Kuruvilla, Associate Director, Baptist Hospital. Sir has highlighted about the significance of effective communication for healthcare workers She highlighted the very important points. And next, I take opportunity, the second speaker of the first day, Dr. Leena Lourdusamy. Madam discussed about the need for the integrated communication skill for undergraduate nursing students. She has very well explained the important significance are highlighted in this inner presentation. Today's second day, Dr. Stanley McAdam, ex-CEO of Baptist Hospital, consultant palliative care, Bangalore Baptist Hospital. Sir has explained in detail about the critical communication skills for palliative care patients and their families. And the last speakers of today's session, Madam Chalby, Associate Professor, Louis Helpton School of Nursing from Texas, USA. She also highlighted and explained about the crucial conversations in simulation in a healthcare setting. And the last, Dr. Dayanand sir. Sir is the backbone of all this program. So, sir is forwarding all our requests through the Advanced Research Department. We are just happening this. All these webinars are happening it. So, I take I convey my special thanks to Dr. Dayanand, and also the special thanks goes to the co-organizers from RV College of Nursing, Mr. Ajay, program organizer, Ms. Sheila, technical expert, and also head of the department of OBG, and Mrs. Navita N, program co-organizers, and also the special help for this program, Mr. Siddeshwar Angdi, sir is associate professor in RV College of Nursing, Madam Gautami, Mrs. Gautami, associate professor, RV College of Nursing, Bangalore, and each and every faculty, we are directly and indirectly supporting for the success of this program. Last but not least, all the principals, there are many principals from the various institutions, and also the professors, HOD, and also the main important participants from RV College of Nursing and Baptist College of Nursing, all other organizations, they have just made this webinar and success. The special thanks to Dr. Leena ma'am for continuous support and encouragement for success of this webinar. Thank you, ma'am. Thank you all for the wonderful webinar happened in a very successful way. Over to you, sir.
Thank you, sir. So I announce the end of this webinar. Thank you all for being with us for the 2 days. Thank you once again.